here, and then Pharm will get going with your last section for this exam. So, as we were talking about yesterday, opioid therapy, what units do we want them in? Morphine. What type of morphine? Oral. Okay, so oral morphine, everything needs to be in that same thing. If someone's on one opioid and they've been on it for a long time, their body's used to it, if we put them on another opioid, is their body going to react differently to that? Yes. So all that is to say that that is our incomplete cross-tolerance. Meaning if we're tolerant to one, we're not 100% tolerant to the other one. Okay, so there's an incomplete cross-tolerance. Whenever that happens, we need to dose reduce. That's all this slide says. And that's what the next couple slides say. So I will say it is difficult trying to go off of other folks' lectures when they have all these materials, and I'm like, it's just a 1-minute statement. So that's what this slide says. If you're on one and you go to something else, we need a dose reduce. Typically, we need a dose reduce by about 25 to 50%. Okay? The more you guys practice, the more you'll figure out kind of what that range is. I have docs in my clinic that will go as high as 70% dose reduction. I'm typically more on the 25% dose reduction, but it really just depends on the patient, what they've been on, kind of what's happening. So what was their baseline tolerance and why were they tolerant to that first one? If someone has uncontrolled pain on the first drug that they're on, so this is that last bullet there. If they have uncontrolled pain and they're tolerant to one opioid, traditionally if you kept them on that opioid, what would you be doing? If they were tolerant on oxy and their pain was uncontrolled, you would do what with the oxy? Increase it. Okay? If we're going to go to another opioid, normally if their pain was controlled, we would decrease it. Because their pain is uncontrolled, we may just keep it the same. Okay? So you can think of that in a way of we would dose reduce for the tolerance, but we would dose increase because they're still in pain. Alright, so these are just all those terms that we talked about. If we're on morphine oral and we go to IV, because we're changing something, because it's the same drug, the amount of tolerance is the same. So we don't need a dose reduce or anything. If it's the same drug, if it's morphine oral to morphine PO, if it's hydromorphone oral to hydromorphone PO, we don't dose reduce for different formulations of the same opioid. So only if you're going from one opioid to another. All right, so let's put it in action. Back to Dave. So what is his current total daily dose of hydrocodone? 40 milligrams of hydrocodone. What is the equivalence of hydrocodone to morphine? They're equal. So how much morphine equivalence is he on? 40. Okay, that's all that says. This next slide is exactly what we just did, but factoring in the fact that we're going to go to something else. Okay, so we're going to need to dose reduce. So this says first we calculate how much are they on. Then we convert that to how much morphine they would be getting. Then we need to dose reduce for that cross tolerance. Then we need to go to our new opioid. Okay, this slide makes it sound so much more harder. So this is one of the things that was in your previous PowerPoint set that I added back in because I didn't know if it would be on your exam for your big exam. This process is not on your current exam. Okay? The concept is, okay, if you're on one and you go to something else, I would expect that you'd be able to understand that. Okay, but applying it won't be on the exam. And then here's an example if someone was on tramadol and we rotated them to hydrocodone, what that would look like. So this would be a fairly simple conversion. This would be a more complex conversion. Again, I don't know if Big Boards is going to ask you guys these types of questions, so I have those examples in there for you for when you guys study for that. So Dave, we already said he's on 40. If we want to go to oxy, so he's on 40, we need to account for cross tolerance. Oxy is a new chemical, our body is not used to it yet. So we need to dose reduce. Let's say we're going to dose reduce by 25%. So he's on 40 of morphine, we would go down to 30. Okay, 25% reduction. Okay. What I had done here was kind of backwards. I actually converted it to oxy first, and then I dose reduced. It's the same thing. Just somewhere in that process, you need to do that dose reduction. So then we can get our dose of oxy, which would be 20 milligrams of oxy. Questions on this process? Feeling okay? So on the exam, you'll get a table very much like this one. Okay, what are the two that are less potent than morphine, that are weaker than morphine? Tramadol and codeine. Okay, so weak opioids are going to be your codeine and tramadol. Okay, if these are in a different order, okay, because not that we're going to try to trick you or anything, but most of your conversion tables are going to be in different orders. Right? So codeine and tramadol are your two weaker opioids, right? So those numbers are going to be bigger. You need more of it to equivalent to what morphine is. Okay? All the ones on the bottom there, they're all stronger than morphine. All right, now Dave, he says, you know what? I think I actually want to stop these things altogether. Like, oh, Dave, we just did some wonderful math for you. So detox. When we're detoxing off of opioids, we already said you don't die from it, but you feel like it. You have all the flu-like symptoms, myalgias, sweating, diarrhea, all the side effects that we get with opioids, now we're just automatically taking them away. Ways that we can do it: if someone is going through detox, we can give them back opioid. Right? We don't want to do that for Dave. He's trying to come off of them. Okay? But if someone comes into the ER and they were on heroin, we could put them on something that is an opioid to replace those effects right away, to help manage their withdrawal symptoms in the short term while we get them over to treatment. So we can give them opioids, we can manage their symptoms. If they're having diarrhea, we can give them loperamide. If they're having nausea, we can give them some Zofran. Or we can do supportive cares. How do we come off of these medications? Typically, we recommend having a plan up front. Don't surprise Dave at his appointment. Get some buy-in, and that's going to be a lot more successful. Be honest with them that these symptoms are something that come up. Get creative with the different formulations and dosings. Okay, which things can you do half tablets of, which things can't. You might actually consider rotating to another opioid, because again, when you rotate from one to another, you're able to do what? Dose reduce. Okay? Sometimes we do that. We just keep rotating patients from one to another, to another, to another, and eventually we get them down and off. The first 50% of coming off opioids is the most well tolerated, so we can go a little bit faster during that first half. Knowing that per all the guidelines that are out there, there is no right way to do it. Okay? A successful taper plan means that we just lower it. Okay? It doesn't have to be off in a month, it doesn't have to be off in a week, it doesn't have to be off in a year. That's typically a question that I'll ask my patients when they're referred to me is, when do you want to get off this medication? And I'll say, I don't know, 6 weeks? Oh, this medication you've been on for 15 years, month and a half is good? So typically my plan is always a year and a half for most of my folks. Okay? Again, it depends on what dose it is. For Dave, I think we could probably go a lot faster. These are some examples of the different supportive medications that we could give our folks. So the CDC guidelines, again, they are wonderful guidelines. The new ones, say the 2012 ones, are the ones that really kind of fueled a lot in the opioid epidemic. And so if you hear things about the CDC guidelines, that's probably what we're talking about. So the new updated ones really encourage being selective with the opioids that we're using, making sure that we're coming off of the opioids safely and appropriately, getting that buy-in, and to not abruptly discontinue things unless there's a life-threatening situation. Go slow, get that buy-in, support that patient. Successful is just coming down. The VA guidelines suggest using a collaborative approach when doing that tapering, and they actually don't recommend a specific plan to do that. So what are the 3 drugs if someone has opioid use disorder that we could use? Methadone, naltrexone, what's the B one? Buprenorphine. Okay. What's bupropion? Antidepressant. Okay. Common mistake. All right. So the clinical pearls are actually going to be a summary of what the CDC guidelines are. So first we need to determine when to initiate opioids. So when can we initiate opioids? When are the best situations? Severe cancer, severe pain, acute procedures, terminal, end of life. Okay. Non-opioids are going to be preferred in subacute and chronic pain. Right, so subacute chronic pain, that's going to be our month plus. Initiate therapy, so opioid therapy with IR rather than ER initially. So something that's short acting first. Always start at the lowest dose and continue to weigh risks and benefits. Weigh those whenever you consider tapering. Make sure that the quantity is sufficient whenever there's severe acute pain. So don't give them a month's supply if they have their wisdom teeth out and that's supposed to hurt for 3 days. Have regular follow-ups whenever you start and increase your dosing. Mitigate risks and offer naloxone. Review the PDMP. Consider tox checks. Use cautions whenever someone's on opioids with another CNS depressant, specifically benzos. And then treat, manage, and support folks that are having opioid use disorder. Altogether, here's our opioid response. Okay, when we add an opioid, these are the things that can show intoxication. Overdose is when we get too much. When we take off that opioid, we can go through that withdrawal and have that detox. If opioids are your newfound passion, I strongly suggest that first reading there. Marilyn McPherson has a wonderful book out called Demystifying Opioid Conversion Calculations. We were able to download it for free at AMC. I'm sure you guys have similar access to your med library. So that is something that if you are on a rotation or at a site and they do a lot of opioid conversions, I'd recommend taking a look at that. They have chapters on fentanyl patches and different things. PC Now, so How to Care Now is a network in Wisconsin where they have different tools as well. Tons of modules and videos. The VA has all these different handouts. They are a little bit outdated and they are very kind of anti-opioid. So just be mindful of that when you're talking with your folks. Questions? Okay. I don't know where Heart is. Sure she'll be here soon. I am currently working on a summary sheet. There were lots of concerns. I would encourage you guys, right, as an outsider, if you have concerns and you know that there's something that has helped you in the past, ask that outsider to provide that to you. Okay? So I will be working on that. I'm about halfway done through it. I'm trying to make it as brief as possible with the intent that you guys will take that. That'll be a good foundation. You can look through some of the other details and apply that to that sheet. Okay? I know Hart very much does not want to do a review. I'm happy to come in and do a review, whether it's a mandatory thing or not. But I will be available and around. My clinic is already canceled, so you guys let me know. I see some hearts. Perfect. Okay? Other thoughts, questions? Okay. Hang tight for a second. Oh, she is just right outside.
Do you think it's silly to pay patients?
I was disoriented.
Yeah, it's okay.
If someone was on this side, I was like, oh, what am I doing?
I just have long arms.
Oh, thank you so much.
Yeah, I know.
It was ahead of my dream.
No, it's okay. You were out of it. You were like,
Dude, yeah.
because I think I said something and you're like, proper response, like you're very well trained.
Oh, God, thank you. still not gone. I would love That's great. No one else does. Exactly. What?
I was also. Oh, of course, she's a
No, you're a big boy. I got a baby boy. Oh, shit, she's
Those with what we were already talking about, looking at pain. So some of this, I'm just gonna like skim over it because you've seen it already. You're gonna see some Tylenol stuff in here again. So we'll just like kind of mosey right along because we're trying to finish, okay? ELOs, same thing that we typically see, right? So make sure you're looking at your mechanism of action, looking at your classes of drugs. So the things that people kind of get confused with on these are going to be like, what is the drug class? Where does it fall? What's urate lowering therapy? What's prophylaxis? Trying to like keep all of that together. So when you're studying, make sure that you're kind of putting the drug classes together, like knowing which drug falls under which type of treatment when we talk about gout. That's the big common thing that I see that gets missed sometimes. So our what do you know? I'm going to go through it and just show us all of the answers. So a topical NSAID that we have that we can use for our hand and our knees, when we talked about hand and knee OA, you're going to have some diclofenac. Most of the time we like to put it on the knees more so. When we talk about putting things on our hands, what's the thing that we're worried about with if I have to put something on my hand? Go like this and putting it in my eyes, right? So that's where we sometimes will hear us talking about that. NSAIDs help with pain and arthritis disease control. We do get pain relief from them, but we don't get the disease modification or like trying to slow down the disease process in our patients who have arthritis. So making sure that you're understanding what the question is asking is going to be a big thing. How soon can we use our colchicine? So when we talk about a lot of our meds for gout, colchicine is one of the big medications that we use when people have like a gouty flare. And so you want to try to use it as soon as you can possibly get it to them, so within 36 hours. Most of the time we use it outside of that window. We don't see as much symptom improvement as we would have hoped, okay? So you kind of try to push it as soon as you can. What's wrong? I was just making sure. Y'all don't look. Whenever I ask that, because I'm trying to make sure I'm doing everything right, and then everybody looks and the people are like, oh, I see. Okay, this is kind of what I was talking about when I was trying to tell you different meds that we have for helping us with the pain that you can feel when you're talking about arthritis versus trying to modify the disease or slow down the progression of the disease. So when we're talking about that, we have our DMARDs. And we'll get into those. There's several different classes that we have, and those are going to help slow down the progression of the disease and hopefully reduce morbidity and mortality in those patients, which is why we like to use them, and that's why we use them later on in the disease, or if somebody is like more moderate or severe in their RA presentation whenever they present to you. Tylenol is the first line for osteoarthritis pain, is a false statement. We'll go through some of that. And then looking at what is our serum urate target for gout. I don't try to make you remember a lot of different levels. This one I want you to look at it and remember because we're going to see it. And a lot of our treatment is trying to target to that goal. And we'll see this in the slides as we go throughout. So less than 6 milligrams per deciliter or less than 5 milligrams per deciliter if there's tophi present. And I have pictures so that we can talk about what tophi is. I'm supposed to be in a meeting that I'm not going to be in. Let me mute my computer. Hold on, y'all. All right, so looking at our osteoarthritis. What's arthritis? Does it feel good? No. You're likely to have it as you continue to get older. My grandma used to say, Billy, you keep living, you wait if you keep living. And I'm like, oh, I kept living, and now I see what she's talking about. So you're going to have a lot of your younger patients even now, especially if somebody has had like some type of surgery. You'll see where they'll end up getting arthritis in that joint or whatever that we did a surgery on. So like this is something that is very common that you're going to see and that you will treat. A lot of your patients are going to be in pain, and all of the things that you talked about before, we're going to apply it, and we're going to specifically look at the difference between our OA and our RA. So when you're looking at your OA, that's your osteoarthritis versus your rheumatoid arthritis. Your OA is more so like the wear and tear, like your cart starts to degenerate. So then eventually what you'll have is kind of like bone on bone. That's where the patients are starting to feel a lot of the pain. Sometimes we send them to ortho, do different injections to try to lubricate that joint again for them so that it's not their bone rubbing against each other. And then your rheumatoid arthritis is more so of an autoimmune disease that patient has that continues to progress over time. And that's where we're using more so sometimes our DMARDs to try to say, okay, when am I going to, or how long can I combat my body, autoimmune, right? So how long can I slow down or stop that immune process in that patient so that they don't have a horrible presentation. This is just showing you again what's happening in our patients who have osteoarthritis. Again, it's kind of like that degenerative thing that continues to happen over time. Most of the time, it's going to be in their weight-bearing joints that they have. So looking at like their hips, their knees, their feet, back. But most of the time, you'll hear people complaining about their knees, their hips, and typically like the hands. Okay, so our treatment goals. We want our patients to be comfortable. We want them to be functional. I dated somebody a long time ago, right? And his dad played in the NFL, and he was like maybe in his 60s, and his hands, like he couldn't change a light bulb because he had arthritis in them so bad. So like think about like seeing like a greater than or less than sign. Each finger like going a different way, and the quality of life and everything else that somebody can end up having because of them just having either form of arthritis can change. So when you're dealing with somebody who is dealing with pain or any of your disease states that you may diagnose someone with, even if we're talking about something like high blood pressure, and you're telling them, hey, you have to take this pill now every day. I always tell y'all to check on your patient's mental health at that point, right? Because now their life has changed. Yes, they may have been the second or third person that you told that to today, but for them, that's their first time hearing it, right? So always ask those baseline questions also. So our big thing is to try to make them comfortable, educate them on what their disease state is, educating them on which medications are better for them to take. Also, you're going to decide when y'all are initiating things and when you want to hold off on some of those other things. They're going to start hearing commercials about their disease state and say, hey, but I saw that on TV, why can't I use that one? And you're going to be like, well, you haven't progressed to that point yet, and we don't want to use that. We're going to hold off on some of these things. So our goal is to try to make them comfortable and to try to decrease the amount of pain that they're having, decrease the immobility that a lot of your patients are going to have. Your non-pharm, talk about diet and weight, right? Because the heavier I am, that's the more weight that I'm going to have on that joint that is already arthritic. So that is also going to create more pain for them. And then looking at strength training to kind of help them build their muscles to where like that's kind of helping carry some of that weight. It's not just all on their bones to kind of, you know, bear the weight itself. And then sometimes, depending on how bad it gets, you can do surgery. It is sometimes not a permanent fix because they will go in there, they will try to clean something out, and then it will come back, okay? Because their bone is going to continue to grow. So we do see sometimes where that does happen, but that is like the last kind of line thing that we're going to do. We're not going to just start somebody off with surgery unless they're super severe. Now, when we're looking at our medications, I put that this is not in order because I know y'all like to have things in order. Depends on how your patient is presenting, right? So however your patient presents is going to dictate what type of medications you're going to use. Because if I'm not in a lot of pain, then you don't need to go to something that's going to be like tramadol. You can give me something more effective if I don't have any contraindications with like an NSAID, right? So looking at what in how your patient presents is a big part of how you're going to treat your patient who has any type of arthritis, okay? Whether it's OA or RA, same thing. We're still going to be looking and saying, how is my patient presenting? Are they very mild on the end of the spectrum, or are they very more on the severe end of the spectrum? So you have your NSAIDs, we have our oral and our topical that we have available. Capsaicin, cross this off because we don't really use it as much anymore. Also thinking about it, all the things that we talked about with capsaicin, we're looking at this and we're talking about the bone pain that people are actually feeling. They've been doing more research with this one and saying that they don't use it as much when they're talking about arthritis. So you won't see it as we go through the slides, it's not going to be on there. Looking at your corticosteroids, this is something that you can use. It is limited because we'll talk about steroids in the next block. The more steroid you use, the more side effects, which we're going to see some of the side effects that we have that can be, some of them irreversible, some of them to where they cause other conditions, comorbidities to occur because we've been on steroids for a very long period of time. Also, the response to these steroids are very variable as to how they work and how long they last our patients. So just looking at that is a different option. Your glucosamine sulfate and your chondroitin, those are herbal things, right, that are over the counter. So those are kind of hit or miss. We're not going to tell people to do that, but you will see some people who come in and say oh, I'm using this and it works well, but I need something else. And you're like, oh, but I thought it worked well. You're in here to come in and talk to me because you need something different, right? So just, these are our different options. Make sure that we're taking off your exhaustion. Looking at our different guidelines that we have, this is what I was telling you about. Depends on how your patient presents, where are they having their arthritis at. Most of the time they can tell you oh, it's in my hands, it's in my knee. The person that I was telling you guys about, it was literally in his entire body. His feet, his hands, his back, his hips, everywhere, his entire body. So when we're talking about that and trying to say, how can I treat this person or how can I make them comfortable, you're going to look at where they're having their pain and then say, all right, what options do I have? So we always try to start with our non-pharmacologic approaches, right? What can I do without a medication to try to help this patient? And even if I give them a medication, I'm still going to try to enforce my non-pharm that we talked about, weight loss, exercise, things like that, because that's just going to enhance how good my medication is working. So when you're looking at your hand OA, you see that you have oral NSAIDs that are an option, and then you also have topical topicals. You have your injections of your corticosteroid, Tylenol, which is kind of lower on the list. Tramadol, was this a control medication or not?
Yes.
Yes. And then you have your duloxetine. Talked about that already too, right? Looking at your knee, you see again, I have orals, I have topicals, I have all those different options. So the core backbone-ish of what you're going to pick is going to be one of these medications depending on where they are presenting. Okay? So all the way across, whether it's their hand, their knee, their hip, I see that I can always use that oral NSAID as being a strong option for me to pick. So the way you're reading this is just telling you the evidence, how strong is that evidence or that recommendation. So this is just saying, hey, I have a strong recommendation that if somebody said that they had any type of hip OA, that they could use an oral NSAID, or I can give them injections with that corticosteroid. Okay. Looking at your hip, when we're talking about the hip, the reason why you don't see topical is because sometimes it's deeper, and our topical may not get to that site, right? Remember we talked about our drugs last semester. If I can't get to the site that I'm trying to treat, then it's no good. There's no point in you taking it. So when we're looking at this, just make sure you understand that you do not see your topical NSAID there like you do in your other two, in your hand and your knee. Okay. Tylenol, same thing that we've already talked about. Limited data, not fantastic. So when we're looking at this, we're only going to our acetaminophen if there is a contraindication as to why I am not allowed to use one of my NSAIDs. Am I getting any anti-inflammatory benefit from using the Tylenol or my acetaminophen? No, because it is not an NSAID, right? So our NSAIDs were helping us with inflammation. This is not going to help me with inflammation, it's just helping me with the pain. Okay, so that's why it doesn't have a lot of evidence or a huge role when we're talking about it in the sense of arthritis. Okay, because I don't have any anti-inflammatory properties. Looking at your NSAIDs, this is going over that same mechanism that you already talked about, looking at your COX-1 versus your COX-2, understanding where you're more likely to see your CV risk versus your bleeding risk, and then understanding that if you start to stack your NSAIDs, you're not necessarily increasing the efficacy, you're just increasing the likelihood that you're going to have more of those adverse effects occur in that patient, okay? So if they're telling you that it's not working, listen to them telling you that it's not working. Say, okay, what else can I do? What else can I supplement this patient with, okay? This, you already saw it, so we were looking at our topicals that you have, and you have your diclofenac that is available, hand or knee. Make sure that you're just counseling your patient. The more that they wash their hands, the more likely that that medication is going to keep coming out, right? So that just, you're going to have to make sure that they're applying it as they're supposed to. Remember, you had your dosing card that we were talking about with your upper versus your lower body. So just looking at that, you had your upper, you had 2, and the lower, you had 4. So just, again, depending on where they're putting it and how you already learned that they need to make sure that they're rubbing that in very well. A lot of your patients are not going to use the dosing card, okay? Sometimes the pharmacy will throw that dosing card in the trash if the patient asks them to take it out of the box, because sometimes the dosing card is like glued to the top of the box instead of being on the actual tube. So sometimes when patients, even if we give them the box, they will take the medication out of the box and just throw it away, and because they have their tube. So when I used to work in the pharmacy, I would tell my staff, hey, take the card out and tape it to the box, tape it to the tube. So when they take out that tube, they're going to see that card. Even if they said that they didn't want us to counsel them, they see that that card is there. So you can just tell them when you prescribe it, hey, don't forget there's a dosing card. It'll tell you how much you're supposed to put. Your steroids. So we haven't talked about steroids in a lot of detail yet. But what do we think that they're used for? What is their role when we're talking about our osteoarthritis? Is it's helping with inflammation, just like we talked about with our NSAIDs. So when you're looking at this, understand that this is not your oral option. These are going to be injections that we're going into that joint, and we're injecting them with a steroid. Okay? So these are no oral options. So no oral corticosteroid when we're looking at it here. Again, with our knee and our hip, we have very good results from our patients. They respond very well to it. And then understanding that you can have side effects with this medication, especially the more often that they use it. So we typically will not see this used more than 3 to 4 times a year. Okay? So with that being said, the response to these are variable. You have some patients who will get their injection and they're like, oh, this is great, and they can hold off until that next 3-month appointment or that next 4-month appointment. You have some people who after a month or 2, they're like, oh, this doesn't work anymore, okay? And they're looking for something else to kind of supplement it. So then it's kind of up to you to have that conversation with them to say, hey, you see that it's not working as well, or sometimes people will start and they'll have a great response and then it kind of starts to taper off where their body is like, yeah, there's that steroid again, like, don't care. But you do have a lot of people where they will respond and they do get very good results from your steroid. Again, your big thing that I want you to remember from here is that you're injecting it, okay? It's going into that joint that is affected. And then when you're looking, also make sure that you're not going over that limit of the 3 to 4 times a year, because we're going to increase the side effects that those patients are going to experience. Looking at our efficacy, we were just talking about this, right? So sometimes they'll have that short term where they're like, oh, I feel so much better. And then it comes back after that first month or 2. So depending on how the injection is given, some providers will give it also with lidocaine. Some providers will inject in the joint with lidocaine first to see if the patient has pain relief there. And if they say, oh yeah, that's it, then they will go in with the steroid and inject there to try to give them some of that relief in that joint. Also, you see, so this initial pain relief seen within 24 to 72 hours, Sometimes it could be from, if they do lidocaine as well, it could be from the lidocaine as to why they are not having that pain at that point. Looking at your peak and when you're expecting to see most of your pain relief, 7 to 10 days, so it's not immediate that they're seeing that response, but again, lasting up to that 1 to 2 months for your patients. Our adverse effects. So this is what we are worried about the more that we administer the medication, okay? The more that I need to take this, the more that I'm going to see my adverse effects, which is why we only give it how many times in a year? 3 to 4. So when I'm looking at my systemic issues, and you're going to see this when we talk about RA also, but when I'm looking at my systemic issues, I'm thinking like issues that could be now affecting me in several different ways, right? Systemic wide. So not in just that spot that you locally injected me. Wherever you locally gave me my injection, I'm probably going to have some pain at that site. I might be red at that site. That's fine. When I'm looking at these systemic side effects, that is more of an issue, right? So you see my hyperglycemia, edema, especially in your patients who are on it for a longer period of time. We say like their face starts to change, I think we call it a moon face, and sometimes they'll have like what we call a buffalo hump, where like they start to have that fat kind of deposit in their backs from them using these steroids for a very long period of time. Their blood pressure will be now not regulated anymore. So if you had someone who was controlled with their diabetes or controlled with their hypertension, maybe now they're not. Okay? Because I have them on a steroid. The longer you have them on it, the more likely they are to experience this. Also, what you can see, even with some of these short-term things, that a big thing is that I see now more is insomnia. Even with like short-term use of some of our steroids. And it's not on this one, it might be on the next one, but you can see where you can have some of that insomnia. Adrenal suppression, we're going to talk about this more whenever we get into the corticosteroid lecture, but the more that somebody takes this on a repeated basis, the more likely you are to see that. Because we're limiting this to the 3 to 4 times a year, you typically are going to see the adrenal suppression because of us using it in OA. All right, tramadol, you've seen all of this stuff before. Big thing with this is understanding that this is a conditional recommendation, so it's not something that they would prefer to give our patient, right? We want to try to use our other medications first. We want to try to use our NSAIDs first, if we can. Looking at this, same issues that y'all already talked about before. Other thing is that you're starting low, going slow. Duloxetine was the other option that we had here, so just refer back to your pain lectures about some of those things that you looked at. I won't ask you anything different. Why, like, this matches up with what you've already seen before. Okay? Adverse effects, we talked about this. So your serotonin syndrome, all of these things that we already went over. Now, this was what we were talking about initially. There are lots of drugs that are on this list that your patients are going to come in with. They're not going to be the things that you're going to say like, hey, I am going to prescribe you these things. But they're going to see, oh, well, such and such uses this, or such and such uses this medication, or fish oil should help me with my joints. And they're going to have lots of supplements. When you do your med rec, make sure that you are asking clarifying questions based off of the condition in which your patient presents, right? So if I tell you that I have joint issues, you should be like, okay, do I know any over-the-counter stuff that people can take for joints? Because you ask them about medications, they're going to just think prescriptions. And they'll be like, oh, I'm not taking anything. And then you'll go, oh, well, what about acetaminophen? Tylenol, do you take? Yes. Oh, and do you take an aspirin? Oh, yeah, take one of those every day. Oh, and I rub icy hot on, and I do all these things. So you have to kind of like lead them when you're doing your med recs to give them some ideas of the things that may not be written by you, but they can just go and grab. Okay, and they can be effective things. So these are our things that we're going to avoid because they're not proven to work. We don't have any response that is like documented well for us. Capsaicin, we try to avoid this too, especially with the hands, because again, we're worried about them putting it in their eye. All right, our RA, or our rheumatoid arthritis. Big thing that I wanted you to remember here was that it's autoimmune. Okay, so it's not the degradation that we talked about before, more so than looking at the autoimmune issue. The only other thing that I wanted you to look at from here is that we have different types of activity that we're worried about. So you see your interleukin here and your TNF alpha. When you're looking at labs and different things, I'm not going to make you diagnose. I'm going to tell you what the person has. So just understand that you're going to have several different labs that you're looking at whenever y'all like dive deeper into this topic. Making sure that ultimately what you see is that you have an increase in inflammation. Okay? So all of these mediators are going to come to whatever that site is that you're having that autoimmune response to, and that's where you're going to see a lot of the inflammation. Your person is going to experience a lot of pain. This can, unlike just when we were talking about OA, where it's going to be in whatever that joint is that's affected, this can affect their entire body. It can affect their eyes, their lungs. I mean, like, this is a very serious thing that can happen to these patients. It can be very debilitating for them also, okay? So understand this is the entire body. It's not just limited to joints. So when we look at our treatment goals and what we're trying to do, I want to control this disease. I want to slow down the body from attacking itself, okay? Because remember, autoimmune disease, because we're talking about RA now, rheumatoid arthritis. Helping them with the pain. Remember, this is not just my joints. This can be everywhere. I can be affecting several different parts of my body. And then also trying to say, all right, what does their quality of life look like? Are they able to still get up and move around? I want to be able to preserve that as long as possible, because once it's gone and they lose it, that's it, okay? So we like to use our disease modifying anti-rheumatic drugs, or our DMARDs. And then when those aren't working, we have other biologics that we can add on to those as well to try to help improve the response that we're getting, okay? They do become more invasive, and meaning like they'll have to start doing injections or infusions when they'll go into a clinic, but it does help slow down that disease so that they can improve that quality of life, which is what we're trying to do, and decrease some of that pain. Non-pharm, same thing, basic stuff that we always talk about. Get them working out, try to make them lose weight. Okay, so all of the basic things to kind of help them take care of themselves. Also, a lot of these people are going to need PT, OT to try to adjust to and learn how to now navigate those new limitations that they may start to form, especially as that disease progresses. Again, not in order of the things that we have that we can treat our patients. So we have our NSAIDs, we have our DMARDs, we have steroids, and then you also see if they have that musculoskeletal pain that we have the Loxetine again on there. So this looks very similar to what we saw in OA, but we didn't have DMARDs that were on our list, okay? So these are our DMARDs that we have because we're trying to slow down the disease. Whereas in our OA, we weren't trying to slow anything down. It was just they're in pain, right? I decided that I wanted to be a track star when I was younger, and now I'm 70-year-old Raina, and my knees are just raggedy, okay? All right. This is kind of how we're looking at treating our patient and what we're going to say, where am I going first? Okay, if my person is and I will tell you if you're dealing with a person who is mild versus if you're dealing with somebody who has moderate or severe disease. Okay, so I don't need you to know that. This gets broken down into how many joints are affected. It's like a whole thing that you would have to know to classify it, but I'm going to tell you where they are. And so when you're looking at this, you have your DMARD monotherapy if I'm mild, okay? I can also sometimes look at potentially just doing acetaminophen. So let's say not acetaminophen, my NSAID. So let's say I already tried that NSAID and it wasn't working, which typically is not going to work for them. Because we know that this is an autoimmune disease, we're always going to put them on some type of DMARD because I want to get on top of it. The sooner I know, the more likely I am to stop that autoimmune attack. Okay, so I can give them something like that NSAID or that the corticosteroid to try to help them until my DMARD works, because it takes a little while for our DMARDs to work. They're a little slow. Okay, so just like the disease progresses slowly, my drugs, my DMARD works slowly. Okay, so this is your key down here, so you can kind of see what they all mean. So you have your hydrochloroquine, your sulfasalazine, methotrexate, and leflunomide that you can use in your patients. If I tell you that I have moderate or high disease activity, This is our gold standard where we'll try to start with just our methotrexate. They'll take that once a week. And we have to be very careful when we're dosing this because this is one of those medications that a lot of your patients may not understand that they're taking something only one time a week. And so we can get overdoses with this medication. So again, we'll talk about this when we get to that slide, but just stress the fact that this is not a daily medication that they're taking whenever they're doing their methotrexate. And then as their disease is going to continue to progress, right? So this could be like they presented, they were pretty bad, but I can try to start with just methotrexate. If that methotrexate doesn't work for them, then I can go ahead and do a combination and add on my other medications, my biologics that we're going to talk about. So your goal is to hold off on your biologics, which are these medications down here, for as long as you can. But you're not going to withhold it if you see that your patient is in more pain, if you see that the disease is starting to win, right? We're trying to get ahead of the disease. So we will start, hey, you're mild. I don't need to really, I can give you some of this DMARD therapy, you're okay, I'm going to just pick one. If you're moderate to high, I can do my monotherapy with my methotrexate, but most likely my patient is going to need me to add on one of my biologics or add on 2 of my conventional, so 2 of these would be added on. Okay, and we'll kind of go over that. And I tried to switch this because we had, when I call up my random 3 people, I think it was 5, we talked about trying to say where do these medications land, and then we're going to get into the actual meds again, okay? So that's why I'm talking about this first. Looking at your treatment modifications. So this is essentially saying like, when do I know what to do next, right? Like when do I know when to progress? When do I know when to say to my patient, hey, I'm gonna, let's try to up the dose on this, or let me try to make you more comfortable, kind of. So your treat to target approach is where you're looking at your patient, you're having a conversation with them, you will set goals, you will let them know what their treatment plan looks like, giving them realistic expectations. Of course, we want to have and achieve remission, but sometimes we're not going to be able to do that. Sometimes we can just decrease the disease activity. We can kind of, like we were saying, slow it down. There's several different check-ins that go along with T to T, so your patient will continue to come back into the to you to try to talk to you about like, hey, how am I going to manage this disease? Looking at this is just again telling you, I would essentially add on another DMARD or go to one of my biologic medications versus trying to put my patient on 3 of those oral or traditional triple therapy, traditional DMARDs. And then again, switching here, don't worry about this, I'm not going to ask you that. I kind of want you to understand these 2 recommendations that are up here at the top. Okay. And as we go through this, will kind of make more sense. Looking at my place in RA for my NSAIDs. What I am trying to use the NSAID for is for that pain control initially, because my DMARDs, are they fast or are they slow? They're slow like the disease, right? They're slow like RA. Remember which arthritis you are using it in. Okay, this is rheumatoid, not osteoarthritis. So just like the disease is slow and progressing slowly, so are my medications. My DMARDs are slow. So what I do is I say, all right, I'm going to give you an NSAID. Unless there's a contraindication, I'm going to give you an NSAID to try to help you with a lot of that pain that you're feeling. Once that DMARD is on there, and they're usually on it for about 6 weeks-ish, most of the time we can then take our patient off of that NSAID because now our DMARD is in their body and it's working fine. Depending on which one you give them, you have some as soon as 2 weeks, you have some that can be up to 6 weeks. So this isn't doing anything with the disease. It's not slowing it down. It is helping with just the symptom. Okay? It is just helping me with my pain. That is all. Okay? Same contraindications that you're worried about, all of the other side effects that we talk about, you're still worried about those. Let me get to our DMARDs and then we'll go on our break. Looking at, again, our corticosteroids that we have available, I want you to just remember that we have corticosteroids available. What do you also notice here versus our OA? What are my formulations, right? Now I have a PO option because I told you it can affect my entire body, right? And if I take something orally, it's likely to be systemic. So that's how you can try to remember. In my RA, I have now an oral corticosteroid option also. I'm not just injecting them in the joints. Because when I'm talking about RA injections, I could be injecting them in 5, 6, 7 different joints that are affected. That's not fun for anybody, especially your patient, okay? Throw them a corticosteroid, say swallow this pill, don't inject them. But then you see all of the different options that you have. Your Medrol, your IV, methylprednisolone is very good for us to try to kind of, especially if they're very, very bad when they present and they're super uncomfortable, we can kind of get that anti-inflammatory response very quickly there. Looking at your clinical uses of your corticosteroids and why we're using them and how we're using them in our RA patient. So bridging, this is kind of what we were just talking about with our NSAID. Because it's going to take a while for my DMARD to work, I can give a corticosteroid to say, hey, let me hold you over until this, until your DMARD kicks in, okay? I also have a burst therapy. So this is where I come to you and I'm having like a huge flare. I am super uncomfortable and you want to get down that inflammation as much as you can for me. You can give them a burst of steroids for 2 to 4 weeks-ish to try to help them kind of calm down that flare that they have. Or you can do your maintenance therapy where you will put them on one of your DMARDs and they will be on a low dose of corticosteroids. This is not an ideal situation, but it is something that you can see because of course the longer that we leave that person on their steroids, ta-da, we have adverse effects. And the longer that we have somebody on a medication, that's usually when we're likely to see more of those adverse effects, right? So again, here are some short-term things that we're typically worried about. So when I'm looking at this for short-term, especially even if I do a burst and my burst is very high, I can see some of these adverse effects occur. So hyperglycemia, the weight gain, your headache and the mood changes, that insomnia can be here. You have GI issues. A lot of your patients will tell you that like they can't tolerate it without having food. Acne can be worse. A lot of your patients will complain about that, especially if they're on it long term, because they'll start to have flares of their acne. And then your long-term issues, and that happens very like quickly. Usually within the first week of them being on like a long-term treatment, you'll see where their acne can kind of flare up. Looking at your long-term issues that we have, so over time, my osteoporosis, right? So that's affecting my bone as well. Hypokalemia, again, the mood disorders, all the other things. So a lot of disturbances outside of just like our typical injection that we were looking at. This is more systemic because I'm likely to use this systemically because I have RA that can affect my entire body. Okay? So please remember this because you're going to see this again. You're going to see it again when we talk about steroids. You're going to see this a couple of times. When we talk about derm, you see this, we're going to see this. Okay? So just be friends with the corticosteroid adverse effects and understand why we don't love to give corticosteroids. Great drug, trash side effects. Okay? When we come back, we'll go over our DMARD. To open our DMARD. What are we using our DMARDs for? RA. And what are they helping us with in RA? Slowing it down, right? It's in our name. Disease modifying. So it's trying to slow it down. You'll see that this slide kind of is showing you where, what is going on? Where your medications can work. Also looking at this, you'll see that you have, we've heard these medications used in different disease states. You'll sometimes see this in other autoimmune diseases. You see these used in cancers, IBS. So some of these meds we'll use in several different places. But we're going to focus on talking about our RA. So looking at this, the sooner we get these on board, the better. Doesn't mean that we're going to move to our biologics. Most of the time we're going to have them on a conventional synthetic or what we will call our traditional DMARD. These are oral medications and we have methotrexate, leflunomide, hydroxychloroquine, and your sulfasalazine. These are our options that we have. Most of the time we will use our top 2 that are up there, most of the time. Because again, remember by the time we hit triple therapy, we don't see that it's as effective, so sometimes we'll want to go ahead and we'll say, oh, I have on these 2 meds, maybe I'll add on a biologic, okay? Or I have these 2 meds, let me switch to a biologic and just keep them on that methotrexate. So I always tell y'all there's more than one way to skin that poor little cat, right? There's more than one way to skin a cat. And we have these guidelines that we can see, but there's several different ways for you to play with them and say, all right, what's best for my patient? What is gonna help me with adherence also for my patient? Help them with that quality of life, because that's what we're worried about in this disease state. So you'll see conventional synthetic, which we also call traditional, and then you have your biologic DMARDs that you have. So we have TNF alpha inhibitors, non-TNF alpha co-stimulating modulators, and then we have our biosimilar DMARDs that we also have that are going to be more targeted, okay? So these are the different types that we're going to go over. When we talked about our benefits, when does my medication kick in? I was telling you that it varies. So this is why you will see us treating with that NSAID, treating with that corticosteroid prior to us having this DMARD on board, or when we start that DMARD, because it's going to take a while. They're not going to see that benefit. They're not going to see any pain relief. They're not going to see that full inflammatory, anti-inflammatory response, okay? So that's why we're seeing that we're saying, all right, as soon as I find out, I'm going to put them on one of these orals. Yes, they can still use that NSAID or acetaminophen if there's a contraindication. Yes, they can still use that, but I'm trying to, or my corticosteroid, but I'm trying to put them on a traditional or a biologic, okay? That is the name of this game. We're racing against time. So, looking at your conventionals that you have methotrexate, which is where we typically like to be. And then you have your mild disease or add-on to methotrexate. We'll usually use your hydroxychloroquine or your cephalazine. And then your moderate to severe patients, we'll see that sometimes they're put on that methotrexate with your leflunomide or your Aravera. Again, the sooner we can get them on the medications, the better. That is the big thing when we're looking at these medications, okay? So, our most effective traditional that we have is going to be your methotrexate. You will see it abbreviated as MTX. Rumitrex is the brand name. Make sure that you're looking at your mechanism of action. So essentially what it is doing is it is decreasing the folates that are needed for the purine synthesis, which then is going to lead to a lot of the adverse effects that we're going to see with this drug. So we'll see a lot of nausea, vomiting, mouth sores, things like that. And that's typically why we'll give this medication with folic acid while you're treating them with that methotrexate. The clinical use, most preferred, that is what I want you to remember, right? We said this like how many times? Methotrexate, most preferred. Let's see. I can use it by itself. I can combine other traditionals to it, or I can put on a biologic with it, right, to get that benefit. As the disease progresses, you're going to see that you're going to start to add on to this methotrexate. Dose once a week. I want you to remember that you're dosing it once a week, okay? When we're looking at the doses that get higher over time, because this is one of those ones where we're kind of like trying to start low, especially if they're presenting and they're more on the milder side, so start low, go slow kind of thing. When we're looking at this, you see that once I hit over that 15 milligram dose, my bioavailability starts to go down. So it's easier for me to approach that 25 now, but make sure that we're not exceeding the 25. The folic acid is something that you're going to use, like I said before, to decrease the adverse effects that we're going to see on the next slide. But if somebody is not responding to that folic acid, we also have leucovorin, which is also the antidote if somebody does overdose on our methotrexate. Okay, so you have leucovorin that you would be giving your patient. Speaking of the methotrexate, if somebody takes too much of it, it is very important for you to tell your patients how often they're supposed to be taking something, especially if they're not taking it every day. Because most people think, oh, I got prescribed this thing, I'm supposed to take it every day. When we want them to take it every day, they don't. When we don't want them to take it every day, that's whenever they will. We had people who would come back to the pharmacy sometimes and they're like, oh, I'm already out of my methotrexate. When did you pick it up? Oh, last week. Like, oh, great. Were you taking this? And how are you taking it? Oh, I take it every day. But you guys only gave me 4. Okay? So, yeah. And I have seen it. Thankfully, it was only once. But just make sure that you're stressing to them, hey, let's set a date. What day do you want to take it on? Oh, you want to take it on a Monday? So on their bottle, you can write, take however many pills that you're going to tell them to take on Monday, every Monday, once a week, so that they are clear and that gives them that reminder of, hey, that's when I need to take it. Adverse effects were some of the things that I was telling you about before, which is why we're trying to take that folic acid. So we have a lot of GI, gastric irritation. You have the mucosal sores that end up developing in their mouth, inflammation in the mouth. So just understand that if you are not supplementing with that folic acid, that is when we can see more of these side effects become pronounced. The longer that they are on it, the more serious these side effects become. So that's where you're seeing the hepatotoxicity, the leukopenia, those types of things happening. So focusing on that is going to be the big thing. Also, know that we need to monitor our patients, okay? So that's why you're seeing this CBC on here. And then I don't need you to remember the frequency. I just want you to remember that you're doing your CBC and your LFTs. Looking at my interactions, this is going to kind of make a little bit of sense because I have all of these different things that I'm worried about to say, hey, I want to make sure that I'm not decreasing methotrexate excretion. Because if I decrease the excretion, my levels of methotrexate going up or down inside of my body. My levels are now going up, which means my side effects went up. The chances of me getting those went up. So if I have something on board, like my NSAID, I can see that, especially if they're taking it for a long period of time or they're taking our higher doses, you're likely to see where the methotrexate excretion can be decreased. When you're looking at your Bactrim, your SMX, TMP, or your Septra, the TMP portion of it or your trimethoprim portion of it can increase toxicity. And then the same thing when we're looking at our probenecid, okay? So just understanding that we're worried about all of these things, and it has MTX or X in it in the name methotrexate. So remember that I should not be giving this to my pregnant women, okay? So they're waiting to have at least one menstrual cycle to wash that drug after that last dose that they took. So they need to have one cycle. And for our men, the same thing that we talked about before, the 3 months, okay? After their last dose. We see this hepatic impairment, renal impairment. This should help you remember, like, these were the things that I was kind of monitoring anyway. If you're looking at somebody who's an alcoholic, we're also worried about them, right? Because of the renal issues and the hepatic issues that they may experience. So just keep these things in mind. If you are giving somebody immunizations, we can also see where their response to the immunization may not be blunted because they're using methotrexate. These are all of our other meds that we had that were conventional, so oral options that you see. You have your leflunomide, sulfasalazine, hydroxychloroquine. Don't worry about the dose and the route or the time to effect. Just look at those bolded adverse effects that I have, and then I want you to look at your monitoring parameters, okay? With your hydroxychloroquine, just seeing that we have lots of visual changes, so that's why we're looking and we're monitoring with those eye exams for our patients who have hydroxychloroquine. Oh, your sulfasalazine. So these are like about that big, some tablets, and they are like an orange looking color. And so when you think about how that tablet is made, that's why we can see where their urine, their tears, their sweat, they're kind of being discolored, okay? And there's so much dye in the pills that when you look at the bottle, like in the pharmacy, the bottle is actually like also orange on the inside, okay? So it will stain their bodily fluids. Remember that. Oh, we have G6PD. Yay. When do y'all remember G6PD from last semester?
Yes.
All right. Okay, your biologic that we have. Looking at this, essentially we want them to try or have been on those oral or our traditional DMARDs before we get to this. These are where we're trying to say, hey, I want to preserve these and keep these as long as I possibly can in my back pocket and treat them with those orals, maintain them on those orals so that I can preserve these, okay? Once they get to this, you know that the disease is kind of is developing and it's unfolding kind of rapidly for your patient. So With these, make sure you're understanding that all of these that you give your patient, okay, all of your biologics can increase the risk of infection in your patient. So if they have any type of active infection, we are not going to start this until we take care of that other infection first. Looking at your mechanism of action, it's kind of in the names, and we'll talk about them because they're subclasses of it, but you see your TNF alpha, your interleukin, they're binding those receptors to try to stop activating those T cells so that we can decrease that progression, decrease the amount of inflammation that we see. We don't know about the pregnancy category, so that's one of those ones that I'm not going to ask you unless I specifically tell you that the drug works great in pregnancy. We're not going to touch on all the other ones. And then looking at our clinical use, most of the time, like I told you, we will combine this with that methotrexate and have on a methotrexate, and they will do their IV or injection of their biologic. These are all of my different TNF alpha inhibitors. So that is telling you your mechanism in that sense, right? So your TNF alpha inhibitors, you see that you have MAB at the end, so that's our monoclonal antibodies again, right? And so they are trying to stop that inflammation that your patient is seeing, but then you can also see that I have that increased risk of that infection. So we're still worried about that. Looking at your black box warnings, you see that you can have an increased risk in some cancers for your patient. So big thing that we are trying to watch out for, especially if somebody has a history of cancer, a family history. So just be mindful of that. Sometimes this is all that we have to give these patients. So just monitoring a lot is what we're going to do because it does have a black box warning. Here are all of our different drugs that we have available. So I want you to start here, like focusing on your drugs. These are all of our TNF alpha inhibitors, okay? Don't want you to look at this dose, but look at how we have all of these routes, right? So they're either gonna have to give themselves this sub-Q injection, or they're gonna have to come in and we're gonna run that infusion for them, okay, in clinic. So just understand this is more time consuming for the patient. They do cost more for your patient, right? Because now I have to come in. It is more invasive for your patient as well. And then we see that effect, how long it's going to take for me for this medication to work. So this is why we were bridging. This is why we can give our NSAIDs or our steroids prior to this medication because it's not working and it hasn't kicked in yet, okay? Adverse reactions are listed here. Again, because I am going to inject that person or I'm infusing them, I'm expecting to see those typical things that we talked about, pain at the injection site, my infusion-related reactions, which is like those flu-like reactions that some patients will get. Looking at your antibody formation, so this is a very, 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 very important point. If somebody is on these medications, it is important that they make their appointments. If they don't meet and make their appointments, what can happen is then the body will start to form antibodies to the drug, which is the equivalent of saying resistance, right? And then our medication is not going to be effective. So once they start these, we are trying to make sure that they are adherent to that medication, that they're sticking to their regimen. If they're doing their sub-Q, make sure that they're getting those refills on time. If they're getting their IVs, are they coming in to get that infusion on time, okay? Increased risk of infection, like we talked about, cancer. What we haven't talked about yet is that reactivation that we can have of TB or if somebody has hepatitis. We will see that sometimes when we start these biologics that they will have that reactivation occur. So increased risk of that as well. So most of the time what we'll do is we will test for, Y'all, my computer is about to die. Sorry, you know these batteries last for like 5 minutes on these battery computers. Okay. So with this, just make sure that we're understanding that there's a lot of things that go into us giving a biologic. So big ideas, when you see biologics, you should be thinking immunosuppression, you should be thinking reactivation of disease, increased risk of infection, TB reactivation. So like they come with a price, but I am helping them be able to move better, right? My monitoring, again, the same things that we have been talking about before. Make sure that you're monitoring their TB, make sure that you're monitoring their hepatitis, signs of infection, right? Because I have an increased risk of infection. Makes sense. So if you remember this, your monitoring makes sense, okay? So just over there. So I don't need you to remember that dose and that time to effect. What I do want you to pay attention to is you have your sotolizumab, Pegol. This one we can use in our pregnant patients. We have had research that says that this one is safe. So that is the one that I want you to remember for your pregnant patient. Okay, now, these are your non-TNF alpha co-stimulation modulators. So here are all of your different drugs that you have. This is just telling you the different way that they work. Again, essentially what we're saying is that they're trying to stop that inflammation that we're seeing. So these were some of those inflammation factors. Remember we talked about that IL in the beginning, that you're gonna, when you pull labs and you're diagnosing people, these are some of those things that you're gonna see. Again, the same thing that we saw before, increased risk of infection, and that reactivation that we see is also possible. Here are your different medications that we have. So abatacept, rituximab, tocilizumab, and your seralutinib. Again, IV or sub-Q formulations of them. They've taken a while to work, right? They're taking a long time to work. So I'm going to use my NSAID or my corticosteroids to treat these patients, especially for some of that pain that they may be feeling prior to. And then I'm going to also probably have that methotrexate already on board as well, because these are usually in combination. Pay attention to your adverse effects. Looking at your rituximab, the fact that you have that TLS as a black box warning. You also see that you have PML that can happen, and also those infusion-related reactions, which are way more serious and can be fatal for some of your patients. So your rituximab is real strong, okay? It has a black box warning, all right? You see that it is a very effective medication. We still do use this medication. You will see lots of commercials for this medication, but just know that it doesn't come without its risk, like most of our other medications. This, where it says infection risk clinically lower, this is just telling you that like you're likely to see immunosuppression when you're looking at these 3 medications versus looking at your abatacept, okay? More patient-friendly, not going to wipe them out completely how these will. So pay attention to those, looking at, where we're monitoring for adverse effects like we typically been looking at. This is going to be your biological DMARDs or your JAK inhibitors. These are more directed at that JAK pathway, so that is the target. I just want you to remember which ones are JAK inhibitors. I don't need you to remember JAK 1, 2, I don't need you to remember all that, or 3, okay? So just look at your different drugs that you have. So you have your tofacitinib, baricitinib, and your upadacitinib. Your adverse effects, these look very similar to what we have already been seeing, right? So they're increasing the risk of infection. You can see different types of viruses be reactivated. So that's how you see the herpes zoster, right? Or our shingles that can happen to our patients. You see an increased risk in cancer. We see that we have these cardiovascular issues that have occurred. And those can be so bad sometimes where they have pulled some of these off of the market. So when we're thinking about our JAK inhibitors, think of these as like last line. Your patients are very refractory. They're not responding to any of our other biologics. And so we can then go more directed and try to get targeted. So this is how you can kind of separate these two. Okay, gout. My grandma used to call it gouch. She's like, why do you call it gouch, Granny? She said, it hurt. So, okay, that works. So when I think about gout, it makes me think about my grandma. So when we look at gout, the big thing that you want to remember here is that we're worried about our uric acid levels. They're high. Whether it is because my body is overproducing it or whether it is because my body is not excreting it enough, I now have high levels in my body and I am in pain if they build up in my joints, okay? So what I want you to know is that here, we're worried about uric acid. It is building up. And that is where I'm having my pain come from. That's all I need y'all to remember from this slide, okay? Because I'm going to tell you to have gout. All right, this was what we were talking about before. So when we say that somebody has hyperuricemia, we're saying that their levels are over 6.8 milligrams per deciliter, okay? That is us classifying them as being hyperuricemic, okay? Now, again, remember what I was telling you. This could be because I am an overproducer or because I am not making, I'm not excreting enough, okay? So therefore, it's gonna just build up in my body. It has to go somewhere, okay? What then happens is it will start to deposit into tissues. And that is where you start to see these crystals start to form. And then we'll look at some pictures of kind of what that looks like. And from what I hear, it hurts, okay? So when we are using our medications, we're trying to get that uric acid buildup out of that person's body, help them get rid of it, help mobilize it out of that joint that it is in. When we talk to our patients, there are several things that we're going to try to tell them to do. A lot of people have issues where they can't eat certain things, or they will have a gout flare, okay? Hey, I had seafood. That was my grandmother's thing. I had seafood, and I know I'm not supposed to eat it, but I just couldn't help it, and I had some of those shrimp, and now my toe hurts, okay? So your suggestion would be what to grandma? Don't eat the seafood. Stay away from the seafood. Stay away from that meat. Stay away from sweetened things, right? Things that we like to eat, okay? So these are the things that you're going to tell them non-pharm wise how to try to avoid or limit the amount of flares. You're going to give your patients medication when you diagnose them with gout, and they're going to use it because they know that they're going to eat seafood, or they know that they're going to do that thing that causes them to have the flare, okay? We're not going to judge them. We're just going to make sure they're not gouging, and we don't want them to hurt, okay? Now, all of this don't need you to worry about. Just understand that there's underlying conditions, there are dietary concerns that we can have that can cause us to have a flare, okay? Our drugs are going to help us treat that flare. Our acute flares that we have are very important, and then when we're talking about our treatment, so that you know how to approach your treatment. So when we're looking at this, the big onset that you'll see, people will go to bed, they'll be perfectly fine. They wake up the next day and they'll tell you like, oh my gosh, I'm in so much pain. And they have the podagra where they have that big toe like that has, it'll look very like this, okay? And they have that uric acid that has built up in that joint. And so we're going to use our meds to say, all right, I need to kind of get that out of there. So these are our tophi that we can see, these little deposits of that uric acid in those joints. Don't look at his fingers. So that is what we're looking at. So all I want you to remember from here is that sometimes they'll go to sleep, they're perfectly fine, they wake up and they're in pain. Okay? Now, my goal is to help them not be in so much pain. My goal is to stop that attack from happening to them, get that uric acid out of their body. I want to lower the level, because the higher that I am, the more likely I am to start to have those tophi start to form. So, my goal of treatment, I need you to remember, is less than 6. Because remember, 6.8 was when I said I was elevated. So my goal of treatment is less than 6. If I have tophi, I am more aggressive, and I need to be less than 5. Okay? So if there's no tophi, I'm like, okay, 6 is my goal. But if I see any types of those deposits, then I'm more aggressive, and I'm trying to get them down to 5, or until their symptoms resolve. Okay? So if you got a person down to 6 and they're still telling you like they're in pain and they're hurting, then that means you need to continue to drop it. So if I ask you a question on the exam, I'm going to be very, it'll be obvious. I'll say, all right, they're still telling you they're in pain. So if their goal was supposed to be 6, but I'm still in pain, that means that you still have to treat me, right? You're not going to stop my medication. Because yes, I hit the number, the goal, but how do I feel still as the patient? Okay? This is our management that we have. So anytime you see acute, you want to think of a flare. This is more so associated with pain that that person is feeling at that time. They went to sleep, they were fine, and they woke up and now they are in pain. That is like your acute flare. When you're looking at your urate lowering therapy, this is us trying to say, hey, these levels are consistently elevated in this patient, and I want to try to have them on some chronic suppression, right? I want to have these medications that they can take on a daily basis to try to suppress those levels in that patient. So for my flares, for my pain, these medications are back again, right? I have my NSAIDs and I have steroids, which we just talked about in our arthritis, but now I have colchicine, which is a drug that is specifically looking at us using it for our gout, okay? So I still got my NSAIDs and my corticosteroids. Now I'm adding on my colchicine for my pain, my acute flares. And then chronic suppression, I have XOIs or xanthine oxidase inhibitors. I have uricosuric agents, and then I have my uricase agents that are going to be available. So this is how we are going to address our patient. You have somebody who has mild to moderate pain. I don't need you to remember how many joints are infected or any of that. I will tell you that they have mild to moderate pain with gout, okay? Don't need you to remember to diagnose them. You can treat them with any one of these medications that we talked about. You can use the NSAID, you can use the colchicine, or you can use the steroid. I'm mild to moderate. If I am more severe, then you are going to combine some of these together, right? So I'm going to have my colchicine with my NSAID. I can do my colchicine or my corticosteroid, depending on how many joints are infected. I could also do intra-articular injections with my steroid for my patients. So it just depends on how they're presenting, okay? So when you're looking at this, you're trying to say, all right, what level of pain do I have? Mild to moderate, or do I have severe? If I'm mild to moderate, I just do one of these three. If I'm severe, then I'm getting creative, right? And I'm adding on. So they'll have some type of dual therapy for me to try to treat them. Okay? That's all this is saying. We good? Now, if you have done this, you're like, okay, cool, I'm just treating them with one of these. Or they had severe pain and I had to combine it. The big thing also that I wanted to mention is that ice is also something that helps them out a lot. Which we typically would be like, oh yeah, put ice on it. That's when you're trying to get people out of your office. This actually helps them, okay, with that pain that they're feeling in addition to their meds. So you put me on my meds, my mono or my combination therapy, depending on if I was mild to moderate versus severe. And then I have an outcome. I have either an adequate response to where you got me to my target, my symptoms have gone away, I feel better, I'm okay. You can then say, this is what you had gout, you educate me about it, and then you can decide on whether or not you want to give me ULT, that chronic suppression. Because I could have a flare and that be the only time that I experience that. Not super likely, but that could happen, okay? Most of the time if somebody has a flare, just give them their ULT just in case they decide to go back in a refill because it's going to take them a while to get to you, okay? So let's say I didn't have a great response. I didn't respond to that treatment that you gave me. So now I can change from one of these, my NSAID, my steroid, or my colchicine. I can try to change it, or I can now try to add on to and treat them how I treated my severe patient on the very first, when we were looking at this slide, okay? So I can switch. I can switch from the NSAID and say, hey, I want to put you on a corticosteroid now. Or I can say, oh, they were on colchicine, let me try this NSAID. Or I can say, all right, let me try to add these together and see if these two things work together. All right? That's as far as I'm going to ask you. We're not getting down that far. If there is now is still an inadequate response, then we're going to refer them. They're not our problem. We're like going to refer them anyway. This is the same thing as that picture, but in words, if you want to see it in words, okay? So same exact slide that you already saw. telling you that you're using monotherapy with the NSAID, the colchicine, or your steroid. You have the ice that you're putting on. If they're not responding to that, then you can try to combine them. If they're severe pain, you're already going to combine them. They're going to use colchicine with one of those things, the NSAID, the steroid, or you can do your injections in your patients with a steroid, okay? Make sure that you're understanding that if you're using that NSAID with a corticosteroid systemically, you are likely to see an increased risk in those adverse effects because they both have GI adverse effects, okay? So it is something that you can see. It would be something that you would just try to monitor in that patient. Hopefully they don't need it for a long period of time. If they do, then you want to switch your combination that would work for that patient. So switch them to something else. This is looking at us and trying to say, all right, what am I doing? How am I trying to address my patient? Typically, if they're having that first flare, we will try to use our NSAID, our colchicine, or our corticosteroid, right? So this is the same thing. What I want you to remember here is that you have to initiate that corticosteroid, your colchicine within 36 hours of whenever they had that flare, okay? If they are on ULT, remember our ULT was for chronic suppression. If they are on ULT, then I can continue it when they're having that flare. But it's something for me to note to say, wow, if they had that flare while they were on chronic suppression, is my dose right? Did they eat something wrong? Like, are we managing that person properly, or do we need to increase our dose of our ULT? So that just makes you kind of start to look and see if there's anything else that you need to do. And then you see that initial flare that patient has does not mean that they need to automatically be on ULT, because I may never have that other attack. I could, but I might not. So, like I say, and what I like practice-wise, I'd be like, okay, here's this med just in case you need it, because it's going to take you a while to get into me, but you probably don't need to take this. It's the same thing when we talked about last semester, like how we talked about like suppressing herpes, like our viral infections, right? I may have a flare or an outbreak and then never have another one again. Same thing with this. I may have that flare that happened and then I may not ever have one again. Doesn't mean that I need to be on chronic suppression. Does not mean I need ULT. And then looking at your medications that could help or not help in this situation, that could worsen your condition because they're increasing the uric acid levels, would be some of the things that we already talked about. So we have our niacin, we have some of our diuretics. Remember we saw some of this where it was like, oh, it can increase that uric acid level, so we wanted to watch out in our patients who had gout. This is a recurrence of that. Your calcium urine inhibitors, I would specifically just tell you that that's what they are. Most of the time we use those for like immunosuppression, things like your tacrolimus, cyclosporin, drugs that you receive. All right, our flares. So when we're talking about our flares, just think of it as gout is a sin, okay? These are our NSAIDs that we have seen that have been proven or studied to be, and they have that indication for gout. You can use other NSAIDs when we're talking about treating gout, but these are the ones that are preferred, okay? So if you see another NSAID, it's not necessarily, like in real life, it's not necessarily the wrong answer. If you see it on the exam, I'm wanting you to know what do I have that is indicated for it. These are my different NSAIDs that are indicated for it. So my Solvenat, my indomethacin, and my naproxen. Again, this is different than what we typically see, right? Because remember, Granny calls it gouge, it hurts. I typically like to start things low, right? And build my way up. And this one, I'm already knowing that they are likely in pain. So I start at my maximum doses to try to, and then I taper them over the first couple of days to try to get them back down, because I don't want them on those high levels for a long period of time. So this is not one of those meds where we're like, hey, we're gonna put you on it and leave you there. We follow up, especially with all of our pain medications that we were talking about. And then same pearls that you've seen already before. Just make sure that you understand your Sulfonat. I don't see this used often. I haven't dispensed it often. Most of the time, we have either the naproxen or the indomethacin that we dispense. So just make sure that you're looking out for that. Mechanism of our colchicine. So our colchicine, how long do I have to use my colchicine? 36 hours. So what this is doing is this is trying to prevent some of those symptoms that we see when we're talking about our gouty flares. So again, this is for a flare. A flare is acute. We're worried about the pain that that person is feeling, not that chronic suppression. So make sure you're understanding which meds you are using and what presentation, okay? If I say ULT, you need to know which one is ULT versus which one is looking at a flare, okay? Which was my pain, my acute onset. I went to sleep and I woke up with a big toe, okay? Looking at your repeat doses. So you will have some people who can have that flare and they're fine. You'll have some people who have several flares, right? I can't stop eating my shrimp. I love the shrimp. I'm going to keep eating my shrimp. So I have to wait 2 weeks before I can use this colchicine again. Okay? So you cannot use it more than that 2-week time frame. So if I had a flare and it was only a week and a half later, I still have to wait now before I can use that colchicine. So I might need to now go to my NSAID or my corticosteroid for that patient because they already used their colchicine for that 2 weeks. We worry about a lot of the accumulation that can happen in these patients. A lot of times they start to have nausea, vomiting, diarrhea. They are not happy. And so most of the time when we're dosing this med, we dose to those symptoms that they have, and that's usually when we'll say, okay. So looking at that, we just don't want it to accumulate, so that's why we wanting to do that. And then I want you to look at your maximum dose. So you see that they're only doing 1.2 milligrams a day, so they're dividing that into twice a day, so every 12 hours. Remember to tell them every 12 hours because we're trying to keep them above in that therapeutic window, okay? Our monitoring things that we're worried for, hepatic, renal failure, if we have any patients that are like that, depends on who, when you're looking this up, make sure that if they do have hepatic issues or renal issues, look it up to see if you're going to need to dose adjust for that. Several interactions that you can see, and then our adverse effects that I was telling you, this is what we kind of dose to. So you see the nausea, vomiting, the diarrhea that can happen in almost 80% of our patients. So that's a lot, right? So am I worried about nausea, vomiting, and diarrhea as an adverse effect if I were asking you something about this? Yes. Okay, because that's a lot of your patients. That's most of your patients. And then you see that you can have some bone marrow suppression. Not very common, but if you have somebody who's already dealing with, and they're already immunocompromised, this can become a bigger issue. Corticosteroids, same stuff that we already looked at. So just look at the fact that you have your injections, you have IM, you have oral. We have several different options that we can use for our patients. Your adverse effects are the same ones that you've seen before. So just paying attention to that. So that is our other option for is this ULT or is this for a flare? Flare. Okay. Now I am on to my ULT. I'm looking at my ULT. These were the same options that we saw listed before, right? So I have my XOIs, my uricosyluric agents, and then I have my uricase. When I look at this uricase, this is kind of in order of how we use these, okay? Your uricase costs a pretty penny. It's more expensive. So we kind of start with our XOIs first, uricosyluric acid agents if those aren't working, and then we can go on to our uricase. And by that point, you're going to be referring them. So looking at our indication, I want you to remember when someone qualifies for ULT. So if they have more than 2 attacks, if they have CKD, I don't expect you to remember the stage. I will just tell you CKD. I want you to remember that. Or if they have stones present, then we are worried about, and we are going to want to put them on ULT, okay? Don't worry about the TO5 portion of it. I'm worried about the 2 or more CKD and they have stones present. XOIs, so like I told you on that previous slide, this is the order in which we typically will treat them, so we like to use those first line. We can give these whenever there is a gouty attack, but most of the time what you're going to see is that we will give them an anti-inflammatory. So like one of those ones that we said were for our flares, we will give them the NSAID, the colchicine, or that steroid because we're going to immobilize that uric acid. So a lot of the times when we put somebody on ULT, the big side effect that we see, especially if we don't pre-medicate, is that they're gonna have a gouty flare, okay? Because now I've taken those little deposits that were there and now I'm trying to get them out of the body with my urate lowering therapy, and therefore they're likely to have a gouty flare, okay? So make sure that you're understanding, hey, if I do XOI, if I do use XOI, I need to also be treating them as if I were treating a flare. So I have my NSAID, my steroid, and what else? NSAID, steroid, colchicine. I have 3 drugs that I use for my flare. Those are also the same 3 drugs that I will try to use prior to putting my person on an XOI. Same drug. And then you see if I can't do my ULT with my XOI, it's not working, it's not effective, then I can kind of move down the line. Okay, so you want to write on here 1, 2, 3. You can write 1, 2, 3. This is your order. You kind of start to go down the line. Okay. Here are our different drugs that we have. Essentially, what we're doing is we're inhibiting that xanthine oxidase, which is essentially what will lead to us having more of that uric acid available. So if I stop that conversion, I'm not going to have that uric acid build up. Okay. So I'm blocking. My target is right here. Inhibit this oxidase, so therefore I don't have this increase of my uric acid. This is again looking at my flares, right, that I told you that can happen whenever you start my XOI, because now that uric acid is moving out of that joint that it's in because I'm trying to lower it, I'm trying to increase the excretion of it, and therefore I have my flares. We have our prophylaxis that we talked about. I don't need you to remember the doses of this. I want you to understand that it still does take a little bit of time, okay? I still need a couple of days where I'm going to start to see my results before those levels start to drop down and actually reflect what I'm looking for. So my goal is 6, unless I have tophi, it is then 5, okay? What if I still have symptoms? Are you stopping at those goals? No. You're going to keep treating me if I'm still having symptoms. When I look at my XOIs, I have my adverse effects. Some of them are not very fun. So your SJS and your TINs are part of what's called allopurinol hypersensitivity syndrome, and that you're more likely to see if you're using your allopurinol option. Also have different things here, your diarrhea, thrombocytopenia, cardiovascular events. So they're not coming without their risk, but we do use these safely in a lot of our patients. When you're looking at your allopurinol versus your febuxostat, we're almost at the end. I'm just going to finish off so we don't have to worry about my name. When you're looking at this, just understand the differences are money. Understand that the differences are, so when you're looking at money, your febuxostat is going to be more expensive than your allopurinol, so you're more likely to prescribe your allopurinol. But remember also with that, your febuxostat can also have more of those thrombolytic events that we were worried about. When you're looking at your allopurinol, you're more likely to see that allopurinol hypersensitivity syndrome, which I was telling you about on the previous slide, which was your SJS and your TINs that you can see in your patients, right? So don't worry about these two, the top 2 bullets, more so than we're worried about. One is more expensive than the other, which is your febuxostat, and it's also causing more of your thrombotic events when you're comparing it to your allopurinol. Your uricosuric agents that you have, probenecid, you also have losartan and fenofibrate that you can use off-label just because they're increasing the uric acid secretion or excretion that occurs. So just understand the big one that I want you to know about is your probenecid. Mechanism of action, again, stopping that urate from being reabsorbed, so therefore I am now excreting more of it. I'm getting it out of my body because I'm not going to be able to reabsorb that. I don't want to right now, right? You see that we can also use our probenecid to say, hey, I want my antibiotics to hang out a little bit longer. We talked about this a little bit in last semester, but you essentially are decreasing the excretion of some of our other meds while getting rid of the urate, okay? So if I had some other medications on board, I can keep them in my system for a little bit longer. I can increase their half-life, and then with my urate, I am getting rid of it. I am excreting it. Clinical use, big things are the things that I have put in bold for you. So I'm adding this on if my XOI is not working well. I do have to take it twice a day, so adherence is something that I'm worried about. Make sure that your patient understands that they are gonna have to take it twice a day. You do see that I have those gouty flares that can also occur with this. So I'm going to try to pre-treat them. I can use my NSAIDs, I can use my colchicine, and that is only for that first 2 to 3 weeks when that drug is now built up in my body. I can drop that pre-treatment. I'm not leaving it on there the entire time. I'm just trying to get those uric acid levels under control, right? They're mobilized now, that's why I have the flare, and then I can drop off my flare medications that I can potentially use. Looking at your patient who have your crystals, we're not going to use that in them, or looking at your patient and making sure that they drink. Okay, they have to stay well hydrated because we're trying to prevent them from forming those uric acid crystals that they could get while they're also taking the medication. Okay. Our interactions, a lot of them, right? We just talked about how we can use this to extend half-lives of drugs so we can affect a lot of those medications. And then looking at if they're using it with a salicylate, that the salicylate could potentially make these medications not as effective. Plogodicase or Caryxtra, this is an IV medication. It is an expensive medication. When you're looking at this, just understand that now I am targeting my urate oxidase. Okay, so I'm trying to decrease or lower again that uric acid level that I have for my patient. Severe or refractory patients, this is very last line medication that we're using. As you see, it is more invasive for our patients. Adverse effects. Oh, what do we have here with all of our ULTs? Another gouty flare that could happen when I initially started. Okay. So that's why you see, again, the prophylaxis being on board. What are our drugs for prophylaxis? Yes, those 3 medications that we use, those same ones are the same ones that we use for our acute flares. Okay, and we need them anytime we're using ULT because our ULTs can cause the acute flare. Okay, so that's a big thing there, and then your infusion reactions that you can occur. And one that is super important, if somebody has heart failure, it can exacerbate their heart failure. They could be now going into some acute decompensated heart failure. So we need to make sure that we're watching out for our heart failure patients and contraindicated in your patients who have G6PD deficiency or if they're on any other ULT. Once they get to this, to your plogodicase, we are stopping everything else and they're just getting their infusion. Okay? We're not adding on to this one. This is the prophylaxis, which we have beat so much. We don't need to keep talking about it. So we have our same drugs, right? We have our colchicine, our NSAIDs, our steroid, which is the prednisone. And you see that we're using these in low dose whenever we start which class of therapy? Urate lowering therapy, okay? These are the same drugs that we use for our flares. And then understanding that while they're on this, while they're on ULT, that they are likely to have that flare. That is why we're putting it on it. That is the role, okay? This is the same thing that is on this picture in words, okay? We don't want to use our corticosteroids first if we can avoid it, right? Because we saw those side effects that happen. So if I can avoid that, then I will avoid that. But if they're not responding to my colchicine or my NSAID, I'm going to use my steroid, okay? That's all this is saying. Prophylaxis, when am I using this? Same things that we already talked about. I'm using it in my patients who are going to have our ULT. I'm going to make sure that if somebody is presenting and they don't have tophi, most of the time they're going to be on prophylaxis for at least 3 months until they hit that target level that I want them to be at. If they had tophi, they're usually going to be on these prophylactic medications for at least 6 months. Okay, so that's the big thing that I want you to look at here, making sure that you're monitoring your patient for their goals, and then looking at if you're not getting those goals, of course we're going to try to titrate our medications to where we do reach our goals. We start to combine them. That's where your art starts to come into play, right? We use our science to make art. Okay? And then if you still aren't hitting with all of our other meds that we were using for our prophylaxis, we still aren't getting our goal that we had on our last line, which was our K-Rickstra. All right. What are the drugs of choice when we were talking about our gouty flares, specifically looking at NSAIDs? So okay, sin, right? Remember it was a sin. The two that we use more likely are going to be these, but sin. True or false? DMARDs are a mainstay of RA and help with disease control. Gout flares may be precipitated by which drug class? ULT. All right, we got it? Yeah, don't say no. Y'all stop. Okay, so we're going to go and do some work right now. I will let